and we will move on to our next session of our guest lectures. I want to call upon stage our chairpersons, Dr. Arup Das বিশ্বাস, Dr. Kanak Kumar Mitra, Dr. Pranab Kumar Bishwas, and our guest lecturer to start with is Dr. Gurmeet Singh Wonder, and after that we will continue with Dr. P. Mohanan. I want to call upon stage our chairperson, Dr. Arup Das বিশ্বাস, Dr. Kanak Kumar Mitra, and Dr. Pranab Kumar Bishwas. Please chair this session.
Good morning. We are going to restart our session after a very unfortunate incident of one of our colleagues. So I think he is well. So I will call upon the next topics is one of the old topic with a revisiting, that is the J curve in hypertension. And the speaker, Dr. Gurmeet Singh Wonder. So Dr. Wonder, please start your lecture.
Thank you, sir. We are happy that our colleague is fine and he still wants to deliver his talk after a while. So we'll have a discussion on wide QRS tachycardia. At the outset, let me thank Dr. Manoranjan Mandal, Dr. P.K. Deb and Dr. M.K. Das for giving me this opportunity to be here with all of you. It's always a pleasure to come to Calcutta, and they've given a topic to me to discuss, which, as the chairperson said, is an old topic, but there is a resurgence in this particular issue because of late the American guidelines, the European guidelines have appeared, and we are tending to control blood pressure to a larger extent, just as we are more aggressive in management of dyslipidemias. And so obviously there is a fear and there is a worry and there is a concern that are we overdoing it or are we doing appropriately? Do we have an evidence base to be more aggressive in controlling blood pressure? Lower the lipids, the better, we all know. But does this hold true for hypertension? And in the next couple of minutes, I'll just discuss with you what our thinking is. We all know out of a world population of about 7.5 billion people, 1.1 billion people suffer from hypertension. Almost 1/3 of the adult population has hypertension, and it's responsible for almost 45% of heart disease related deaths and 50% of stroke related deaths. India constitutes today 18% of the world population, and whatever we discuss with regards to any public health disease has to be addressed separately for Indians because we are genetically not similar to others. Socially, our lifestyles are so different. Our healthcare economic structure is not so same. We eat differently, our lifestyles are very different. And so we will in the end see how this evidence base today with regards to hypertension, aggression of treatment, how low to go, impacts Indians, because we all realize, although in the United States today the awareness of hypertension is to the tune of 80%, and 50% people have adequately controlled blood pressures. The same figures in Indians, in the urbanites, only 50% people are aware of hypertension. About 30% people in rural areas are aware of hypertension. And 20% of urbanites and 10% of Indian ruralites have good control of blood pressure. So we are still struggling in this country for achieving whatever landmarks, whatever parameters we set. We are not even reaching there in terms of control of blood pressure. So what is going to impact public health is if we are able to achieve, make larger population aware of hypertension and achieve good controls in a larger percentage of these people, and so we can impact mortality in our patients. Why we treat hypertension, we all know, because 50% of them are going to die of coronary disease, heart failure, 1/3 of them die of strokes, and about 15% of them die of renal failure. We all know this beautiful data given from the prospective studies collaboration that blood pressure, when it goes beyond 115/75, for every 20 millimeters systolic and 10 millimeter diastolic rise, there is a doubling of mortality. So we truly are looking at a situation where the optimal blood pressure, this is from the Indian hypertension guidelines that we gave in 2013, the optimal pressure is 120 by 80. Normal could be 130 by less than 85. And then we have this high normal. We did not like the pre-hypertension term that the JNC 7 gave, and then they themselves discarded it, and we staged it. So optimal blood pressures are less. But Dr. Cruikshank way back in 87 published, and he made us aware of this fact. Is blood pressure control similar? Are we able to reduce mortality to the same extent as someone who does not have hypertension? Or still there is a residual increased risk of coronary disease, renal failure, strokes that is left? And he looked at that time, atenolol was the most commonly used drug. They had 900 patients from United Kingdom. They found that this kind of a curve exists. And he showed us that beyond 85 to 90 at that time was possibly the best pressures to achieve, because we didn't have very good drugs and we didn't have evidence for reduction of mortality by overall risk reduction. So this is what generated interest in terms of blood pressure lowering, how low we need to go, and Dr. Cruikshank, and some people even call it as the Cruikshank's curve. And then this beautiful study came in 98 in Lancet, the HOT study. They were looking at, does it make a difference if we have a more intensive arm and a less intensive? And they were not able to achieve blood pressures to that extent, because as I said, good blood pressure reducing drugs were not available. But still they showed that benefit of lowering diastolic pressures to about 80, and the HOT study in that sense was a positive trial. Then the NHLBI trial, the ACCORD study came, because we used to believe that diabetics are at greater risk of consequences of hypertension, because multiple risk factors, when they occur together, they impact mortality to a larger extent. And so we looked at this, in this particular study, they looked at a more intensive control in comparison to a less intensive control, but they found it was a negative trial. This study could not show a reduction in mortality with a, so there was a kind of a mixed basket. Some studies were showing us be more aggressive, control blood pressures to a larger extent. Some studies, and around 28, we had the all-hat study, the largest study ever to have been done in hypertensive people, 40,000 patients. It eliminated doxazosine as an antihypertensive agent because we realized more heart failure. But it did show, from a very drug-centric approach, it showed us greater reduction in blood pressure, greater number reduction, impacted mortality more than what drug you chose. Whether you chose the newer agents, ACE inhibitor, calcium blockers, or the previous diuretics, it did not make that much of a difference. The difference was in terms of how much blood pressure reductions we achieved. And so our 2013 Indian hypertension guidelines showed us something like the targets that we needed to achieve were 140 by 90 in most people. Diabetics, we needed to be more aggressive. Post-stroke, again, we needed to be. And elderly, although we all know elderlies derive more benefits out of blood pressure reduction, we still were a little bit less aggressive. And see, this is what the JNC 8, actually there was no JNC 8 because JNC finished after the JNC 7, but this group of people, especially Dr. Raymond Townsend, they collected together and they published, and what they showed, there was a huge amount of criticism against this particular. Look at how the Americans have changed the paradigm. At that time they said age more than 60, start treatment and goal should be 150 by 90. So they were truly very, very kind of complacent in terms of elderly, where we derive greater benefits. And this was totally in discordance with what they have shown in the latest ACC guidelines. And I just brought this slide which I used to show in 2015 at that time. I used to say that J-curve exists. We had evidence at that time, couple of years back, when we used to say it exists for MI, it doesn't exist for CVA, because greater reductions reduce CVA incidence, reduce renal failure incidence to a larger extent. And we did recognize at that time that blood pressure, diastolic pressures because of coronary steal and reduction of coronary pulse pressure, we should be able to have pressures beyond 70 to 75, and we should not reduce below that level. Systolic. So at that time we used to believe that overall cardio-renal cerebral risk reduction achieve a blood pressure of less than 140. And so this is from the Indian hypertension guidelines. From the second guidelines, when we said lower the better, we changed it, and we at that time said now we realize that there is a J-shaped curve which does exist. especially for the non-revascularized coronary artery disease patients. For revascularized, we could be more aggressive. And we also said caution should be see, these guidelines we gave a couple of years back and how our perspective has changed. I'll show you in the next couple of minutes how we have become more aggressive. It is primarily because of this study, the SPRINT trial, another trial done by the NIH, the NHLBI. It's a huge trial done in multiple centers in US. And what they were looking at is an intensive arm with a target blood pressure of 120 and a standard treatment. And the difference from the HOT study was they were able to achieve the target blood pressures they were trying to achieve. And so it's not only that, what they took, individuals that they took were, this particular trial has changed the way we look at hypertension. Along with the HOPE-3 trial, we look at high-risk individuals. Even if the blood pressure was 130 to 180, the amount of benefits that were derived in each tertile was similar, whether we were dealing with lower blood pressure tertiles or with higher blood pressure segments. But people who had more risks, those who had cardiovascular disease, those who had chronic kidney disease, who had a 10-year CV risk of more than 15%, and elderly. See a paradigm change in our thought process. Earlier we used to say elderly, be less aggressive, they will have more. Now this is a high-risk subset of patients where the SPRINT study showed, and the study had to be terminated at 3.5 years because the hazards ratio was 0.7, and we had a proof that more aggressive, greater reduction in systolic blood pressure results in greater reduction in mortality. And we today also have drugs. We know most patients will be treated with multiple agents, and so we have evidence that more aggressive. And so these 4 guidelines which have come after that, the Australian, the Canadian, the American, and the European, I'll just dwell upon these. Now, the Americans have changed the total perspective. They've changed the definition of hypertension to 130 by 80, inspired by this SPRINT trial, from a 140 by 90 definition, which is, so they call this as normal, less than 120 by 80. And something that you and I, in the Indian guidelines, in the European guidelines, we call it as high normal blood pressure, they call it as hypertension stage 1. And anything that we call hypertension is stage 2 hypertension. So their redefinition of hypertension has changed the perspective. And today, from a 29 to 30% population of hypertension in US, there is a 12 to 13% increase, and almost 43% of the US population is suffering for hypertension. And you can derive, because in India also we have a 29% prevalence of hypertension, so you can derive almost half of our population would be hypertensive. What they say is that you treat if someone has these risk factors: age more than 75, 10-year risk more than 15%, CKD, CVD. So be more aggressive in this subset of patients as against who is a low risk. So this is a new perspective which has been added to our thinking process. But the topic for me is how low can we go and how low do we need to go? And this is what the American guidelines have so beautifully, I would say, simplified, that the targets should be 130 by 80 in all. In people who are high risk, you start at 130/80. In people who are not so high risk, who do not have one of those 4 things, CKD, CVD, age more than 75, or a 10-year risk of more than 15%, you can start at 140 by 90. Now, subsequent to these guidelines, the European guidelines have come. The previous European guidelines in 2013 showed a systolic blood pressure goal of 140. But what changes have they made inspired by the SPRINT trial? Europeans are generally a little bit more sober, less aggressive, but see what they do. They also feel similarly. The first objective should be to bring it less than 140 by 90, but if the treatment is well tolerated, bring it down to 130 by 80. In less than 65, you can even bring it down to between 120 to 130. So similar aggressive approach between the two. And this is what we showed in an editorial which we published in the European Journal, Hypertension Journal, European Journal of Cardiology, that although the definition of hypertension is dissimilar between the 2017 American and the European guidelines, but the blood pressure targets they are all giving are similar, that is 130 by 80. And this is a significant change. Lower blood pressure thresholds and treatment targets now we have for elderly people. And it is recommended that never deny treatment on the basis of age, although we must look at the physiological age of an individual rather than the chronological age, because for a very active 80 years, you will need to be more aggressive, but for a not so active 80 years, you may not be that aggressive. I'll just end in another 5 minutes by, if I'm allowed to take some overshoot of my time because we missed a talk. This is a clarifier registry, a large registry, which of course has shown that, this is a new concept now which I'm going to talk. Systolic blood pressure of more than 140 and a diastolic blood pressure of more than 80 is associated with increased risk of CV events, known to all of you and me, and we all know this. Now, this particular study shows a systolic pressure of less than 120 also associated with increased risk for primary outcomes. Similarly, a diastolic blood pressure of less than 70 also associated with an increase. So it's not only the high pressure, but it is also lower than a certain level, which is associated with an increase. Now, inspired by this clarify, they went back and looked at the on-target, the transcend trials which were previous, and this data is published in the European Heart Journal a couple of months back. And what they found was similar. For a blood pressure achieved between 120 to 140, a systolic blood pressure in the range of 70 to 80 is ideal. Anything beyond that, higher or lower, is detrimental. We all know we cannot limit blood pressure to very narrow ranges, and individuals, the therapy of hypertension has to be individualized. You cannot generalize. But still, these studies do give us some guidelines as to close to what should we remain. Now, this is the latest, actually, this is published last week only online, and what it shows is that whenever we try to interpolate data from high-risk individuals where hypertension trials have been done, and we try to use them for low-risk individuals, there is no evidence that these people get any benefits. In fact, there is increased risk of adverse events. So you essentially need to look at a hypertensive in terms of his risk factors. If he has CVD, CKD, age more than 75, associated other risk factors, be more aggressive and try to achieve lower pressures. And just look at the European guidelines. Very simplistic algorithm has been given here. Whether a person belongs to less than 65, just 1 minute I'll take, I'm sorry. More than 85, the diastolic blood pressures that you need to achieve are similar, 70 to 80, less than 80, more than 70. Targets, if you are younger individuals, target them to 130. More than that, whether they are between 65 or even more than 80, between 130 to 40, that is essentially. If someone has coronary artery disease, do not bring blood pressures to lower than 120 systolic. Keep it as close to this range. Diastolic, keep it as close to this range. And so we actually published this editorial in the Indian Journal of Medical Research. Indians are different. We know our hypertension is different. We relatively early have hypertension and coronary artery disease. We still have, although we are seeing a rural-urban convergence now, but still there is a significant difference in the rural and urban prevalence of some of these diseases. We have syndrome X. We have clustering of risk factors. We have significant seasonal variations. Summers, our blood pressures come down. Winters, they go up. And the average blood pressure in our population is rising, whereas the average blood pressure in all other races is going down. So we are different, and blood pressures will need to be treated differently. And that's what we published last year in the European Heart Journal, when we gave our perspective with regarding to the optimal blood pressure goals that are recommended by these latest guidelines. What is the Indian perspective? In fact, we felt that Indians may benefit most because we have a higher risk than these people. Although our economic systems are different, our healthcare structures are different, but we are likely to benefit. And same we told in circulation last year when the American guidelines came. We in fact, I'll just quote from this editorial, countries like India with its vast population of patients with elevated blood pressure and its complications will be the ultimate beneficiaries of a militant approach to combat the dangers. Of course, we realize there is a J-shaped curve, but we still need to, in a larger percentage of population, reach the target blood pressures so that we impart benefits to a larger number of people. Thank you very much.
Thank you, Dr. Gurpreet, for your excellent elaboration of this very important issue. As this is a guest lecture, so it is customary not to ask any question, but as this is a very relevant topic, 1 or 2 important comments may be allowed from the audience. And if there is no comment, I have some comment to Dr. Gurpit. So what should be the message that the ideal diastolic blood pressure or systolic blood pressure, number one. Number two, there are some subgroup of population, of hypertensive population, where systolic pressure is very high, but the diastolic pressure is staggering at 70. And to reduce the systolic pressure, diastolic pressure is further reduced. So should you allow to reduce the systolic blood pressure in this situation? And first question is what is the actual cutoff value for practical message for the general practitioners and for overall practitioners?
The cutoff values are coming down. That is one significant change that has happened as compared to the previous. What we realize is that we need to be more aggressive, and we need to bring blood pressure down. We know systolic blood pressure is more difficult to control. Elderly have more of systolic hypertension. And when we bring down the systolic, the diastolic follows. The diastolic will come down. And an increased pulse pressure in an elderly individual is a marker of higher mortality. But what we today look at, if you look at what are the significant changes that have happened in our thinking, we are more aggressive. We need to bring down blood pressures to a larger extent. Home blood pressure monitoring has come to stay, and in India we should follow that. We should bring overall risk of an individual. Statin usage has increased, and we need to reduce the overall risk of our patient. In terms of numbers, for the first time, European guidelines have given a lower limit of 120 systolic and 70 diastolic. So we should aim at not bringing blood pressures to lower than that. In individuals who have coronary artery disease, non-revascularized, we should be cautious. Elderly individuals who are not active, they are to be treated differently as compared to active elderly individuals. Elderly derive greater benefit. We know from the time of SHEP trial for almost last 40 years that elderly derive more benefit for blood pressure reduction than younger. So we need to be equally aggressive in that.
So cutoff value for is 70.
Yeah.
I think it should be 70. So thank you, Dr. Gurpit. So we will next to our next speaker.
Okay, now we have our very CSI active speaker, and he is erudite speaker coming all the way from Thrissur, Dr. Mohananand. He will be speaking again on a very important topic and relevant topic. Welcome, Dr. Mohananand. Your topic is obstructive sleep apnea and CVD.
Thank you, respected Chair. And my thanks are to the CSI West Bengal team for giving me this opportunity to be amongst friends and dear ones. 1/3 of the human life, all of us, are spent in sleep. And we have heard very funny stories about people who snort or snores, rattling their windows or awakening their neighbors. But many a time, when you ask them, people refuse to say that. Do I snore? Even if it is, I'm snoring at a Richter scale. But then possibly it's our fault, our physician's fault also, that we don't routinely ask these questions. So my idea today will be to mainly discuss about, even though I have listed a few agendas, mine is essentially to discuss on, does obstructive sleep apnea causes cardiovascular disease? Is it a causative agent? Or it just augments the existing cardiovascular disease? And the third discussion point will be, by managing obstructive sleep apnea, can we bring down cardiovascular disease? This is a tricky area, but we will try to see. These are the various subtypes of sleep apnea, even though 90% of the sleep apneas are obstructive sleep apneas, where the pharyngeal muscles collapses, and that results in, despite the ventilatory efforts, The second important part of sleep apnea is a central sleep apnea, which we have seen right from our days of our third year. We have been told about the Cane-Stokes breathing that we see in stroke situation or in situations of heart failure. And you have a combination. But mind you, the 90%, as you have seen, of 90% of the sleep apneas are OSA. And these will be the definitions. No? Most of them will be hypopneas, where the airflow is reduced for more than 10 seconds. It's not an absolute cessation like an apnea. And you have something called an apnea-hypopnea index. And the severity of your obstructive sleep apnea is graded according to, if it is less than 5, it is normal, mild, moderate, and severe. So that is the definitions of the. If you look at the prevalence, that prevalence will vary depending upon the subtype. See, if I am looking at a mild OSA, then I will have a very high prevalence. So the prevalence rate may vary, but generally, these are, and this is an astounding figure. See, look at that. And if somebody says 80%, there is an 80% prevalence of obstructive sleep apnea in patients with drug-resistant hypertension, that was very, very staggering level. And you could see that its role in other cardiovascular diseases are also equally important. Of course, we know that as we grow older, we have increasing chances, and the other confounding factors which are involved in the genesis of OSA are being male obese. Of course, we are aware of the fact that obesity is a substrate for OSA, and especially when you have a thick neck, you have a higher chances it when you have a craniofacial predisposition. And now these are the other substrate which will make one develop an obstructive sleep apnea. As I said, if I am taking more than the severe form, then the prevalence may be a little lesser. But if I am taking the milder form, the OSA will be higher. And this is again something very, 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 very astounding. So you look at the odds hazard ratio of a severe obstructive sleep apnea. It is something almost akin to a diabetic status. Of course, I'm not saying that obesity invites the genesis of diabetes, invites OSA. There are mixed bags. And we are not here, we are discussing purely a vascular diseases related to OSA. We are not touching on to the metabolic aspects of obstructive sleep apnea. But this is very astounding figures. The hazard ratio seems to be more than 3 when it comes to severe obstructive sleep apnea. And you have a quite number of observational data, even though I will say the randomized controlled trials with OSA and the cardiovascular disease are not to the extent that we would have believed by the sheer prevalence of it, but all the observational studies and the other registries has shown the mortality definitely increases with increasing severity. When we sleep normally, what's happening is that the reduction in the sympathetic activity and increasing in the parasympathetic activity, and this autonomic milieu grossly undergo change when somebody develops obstructive sleep apnea. This is a normal breathing, and this is partly, and when you have a complete apnea, there is absolute cessation. So this cessation of respiration leads on to a whole lot of things. I know it's a little complex slide, and maybe we should go and skip and go to this, because a combination of this respiratory instability in combination with others, again, leads on to a whole lot of things. A pathobiological situation where principally you have an increasing sympathetic activity, then metabolic dysregulation, inflammation, cytokine activation, all sorts of things happen, resulting on to endothelial dysfunction, and then heart failure, coronary heart disease, atrial fibrillation, and whatnot. This is again interesting. When you have an upper airway obstruction, there is a huge shifting in the intrathoracic pressure leading on to a volume overloading of the right-sided chambers, which may even bang on to the left ventricle, resulting in, that is what's happening in many of the situations of heart failure, the prototype B. Does that mean we should be screening every guy with a obstructive sleep apnea? At least the US Preventive Task Force did not feel that we should be screening everybody with obesity because of the obvious reasons. Because obesity is so prevalent in US, we are not far lagging behind, I know that. But diagnosing OSA, many a time cardiologists and physicians are not experts in diagnosing sleep apnea because we don't know how to interpret a polysomnogram, which is actually the gold standard investigation. But then there are other various scales or scoring system. Whenever somebody comes with symptoms of obstructive sleep apnea, like a daytime somnolence, which is the classic symptom that they will say, of course, I may say that, oh, he's a lazy guy. But it's better that we assess his symptomatic status, and possibly if you're suspecting obstructive sleep apnea, then the best investigation for us to do will be a polysomnogram, and you have the different grades of hypopnea, the severity of the, and we can even make a distinction between whether it is an obstructive sleep apnea or a non-obstructive central apnea by doing a polysomnogram. Now you have various thermistors. It's a complex investigation, I will say, and not every center are possibly equipped with that. But this is the gold standard to recognize obstructive sleep apnea. And you can, it looks very beautiful to look at, but it's difficult to comprehend, at least to me. But then you have long process of diagnosing that this particular gentleman has a significant obstructive sleep apnea. And this is the way that a sampled report of polysomnogram will look like. And it's easy to interpret if you get a report like that. Okay. So what does it leads on to? It leads on to a whole lot of cardiovascular situations, and possibly, now again you could see here. See, these are the lists of diseases, vascular disease that has been attributed to increasing prevalence of obstructive sleep apnea. And if you look at the multivariate, as I said, the confusion galore is that when you have an obese person and he has OSA, but he has also hypertension, metabolic syndrome, dysglycemia, dyslipidemia, and you don't know what is the contributing factor. Is it all OSA? But then multivariate analysis also has shown that OSA has significant correlation with hypertension, resistant hypertension, which we have been knowing for last many, many years. And this is what you have now. As the significance of the OSA increases, you have higher and higher number of persons with resistant hypertension happening. And you could, it's basically a multifactorial reasons that people with resistant hypertension are resistant, because one of the simplest of the reason could be if you can sit down and spend some 5 minutes with him, find out whether the gentleman has an obstructive sleep apnea. See, the severity of the OSA is related to severity of the resistant hypertension. We have some data in adult and also in children. NCPAP means nasal, which we basically use for babies. So we have quite substantial amount of data which gives us that there is substantial reduction. We could bring down the blood pressure substantially when we use CPAP or BiPAP. The second area of importance related to OSA is heart failure. And here, again, heart failure is the big killer these days. And look at that. Now, there is a significant amount of person with heart failure has, it's maybe a reciprocal relationship between OSA and heart failure, and both contributing to both. Now, see, a patient with heart failure has central apnea, and OSA by itself make the heart failure patient susceptible to die suddenly. Both reduced ejection fraction heart failure rough and heart failure puff are related with OSA. It may be a good idea, especially with heart failure with preserved ejection fraction, because there are not much pharmacological armamentarium there. It may be a good idea to use the CPAP, even though I should say the randomized control trial, you must be aware of the SAVE trial, not the old SAVE trial of Ramipril, but the SAVE trial of CPAP in heart failure, where they have not shown significant improvement in heart failure with reduced ejection fraction. It may be another ball game in heart failure with preserved ejection fraction. So you have very many reasons. The pathobiology of heart failure and CSI is depicted here, and I don't need to. It is basically a dysautonomia and a volume shifting which adds on to the miseries of heart failure patients. Okay, and if you chart the survival plots, you can definitely see that patient with increasing obstruction has decreasing survival, and patients who are on treatment, essentially with CPAP, have some improvement, not in the hard outcomes, but in the improvement in ejection fraction, improvement in the quality of life, improvement in even the 6-minute walk test, not improvement in the mortality. Okay, right. So even in asymptomatic LV dysfunction, you could see that sleep apnea has a significant role to play. It is not the significant heart failure, the class 3 or class 4. We mentioned about the central sleep apnea and its relationship with heart failure, which we see very, very, very commonly. The third vascular disease which has been associated often is the coronary artery disease, where I'm not very on strong footing. We don't have a solid evidence to say that there is a increasing relationship with severity of OSA and coronary artery disease. But then we have more and more data coming, the play of interleukins, the cytotoxins, and inflammatory markers. And they may have a role in the genesis of one of the very many reasons why people get CAD, maybe obstructive sleep apnea, because we have at least observational data saying that people with obstructive sleep apnea has higher proclivity to develop coronary artery disease. This is another interesting observation people have noted. Their chance to die suddenly, people with OSA say suddenly die from 12 midnight to 6 a.m. and that has been shown in very many observational studies. Whether it is due to ventricular tachyarrhythmia, people have not studied extensively, but this is something which has been there. The prevalence of arrhythmia, especially atrial fibrillation, and people with atrial fibrillation who refuses to abate with ablation, beware, they may be having obstructive sleep apnea. We have large number of data about atrial fibrillation and disordered sleep breathing during sleep. And all these data suggest that there could be a relation between atrial fibrillation, the so-called lone atrial fibrillation, if somebody says, even though we don't use the lone atrial fibrillation anymore. But then if you find a person with atrial fibrillation and you don't find anything, there could be a underlying OSA. Again, relation between stroke and OSA are increasingly known. We have a higher percentage of patients with OSA developing strokes and deaths. Just like systemic hypertension, we have some data which shows that OSA are related to development of, obviously, but chances of people with OSA developing severe PAH are rare. Now coming to the last maybe couple of slides, what about the mortality? You could see here, when you treat OSA with CPAP or BiPAP or any other mandibular devices or any other devices, even now they have phrenic nerve stimulation techniques coming up. You could see that there is some improvement in the quality of life or in the softer outcomes, not the hard outcomes. We have a large number of data and meta-analysis which shows that CPAP may have some place. As I said, it may not improve the mortality, but it improves very many things like quality of life, ejection fraction, or your blood pressure values. And concluding, ladies and gentlemen, OSA is an unrecognized cardiovascular risk factor, and I think as clinicians we should be spending more time to assess the sleep pattern of patient with, especially when you have patient with resistant hypertension, patient with atrial fibrillation, undetected stroke or heart failure. Please spend some more time with them, assess whether they have OSA, and try to manage them with either any of those devices that is available to you. Thank you very much for your kind attention.
As it is a guest lecture, there no question is allowed. So thank Dr. P.P. Mohan.
Just can I have one query?
Please.
Whether we should avoid beta blocker in obstructive sleep apnea.
I mean, basically, unless the patient is dependent on a beta agonist, we don't need to.
No,
Because-
beta agonist.
I mean, unless he is dependent on a beta agonist, like he is dependent on your inhalers, nebulizers, because most of these patients have asymptomatic LV dysfunction, as we have seen the data. So beta blocker should be given. It is not a contraindication. Only thing is, if you have severe bronchospasm, then only avoid beta
Because
blocker.
chest physician, they recommend to avoid this.
They have at the whiff of a rhonchi, they will stop, which we should not
Physicians
pursue.
avoid this due to chest condition or due to CBD condition?
Overall condition, whether beta blocker will aggravate the obstructive.
Not generally, not generally, because essentially it's the dystonia of your pharyngeal muscle, which is beta blockers does not increase OSA. Thank you.
Usually, COPD and emphysematous patients has got less chance of OSA, whereas more structural micrognathia and short stature, low lung volume, those are people
Yeah.
who are prone to develop OSA.
Thank you.
Last speech by Dr. Arup Das বিশ্বাস, does vaccination improves outcome in heart failure in clinical practice? Instead of Dr. B.P. Singh's lecture, he is absent, and everybody is well accustomed with Dr. Arup Das বিশ্বাs lecture, so listen to him.